Okay, so today we're going to talk about scoliosis. It is June, and that is our awareness month for scoliosis. So if you could introduce yourself to everybody.
Hi, Lori. I'm Clay Elswick, one of the neurosurgeons at Medical City in Arlington. I have background training in complex and reconstructive spine surgery, and so scoliosis is actually a particular interest of mine.
Oh, okay. So tell us a little bit about yourself. How long have you been here?
So I've come back to the practice in the area now for about a year. I'm originally from Arlington, Texas, and homegrown local boy, and trained abroad. And part of my training was in Arkansas and in Michigan, and then we've come back now to Texas and started practice about a year.
Okay. And so what are the main things that you do in your practice?
So it's actually a general neurosurgery practice. We do everything from head and spine trauma, degenerative conditions of the spine, tumor conditions of the spine, and then we do brain tumors. We do and then some other conditions of spinal fluid disorders of the brain.
Okay. And how did you get interested in scoliosis? You said it was one of your interests.
Yeah. So when I was a fellow at the University of Michigan, the preceding year, we treated this condition it's a common condition that we see in adults, and it's a common cause of back pain, morbidity, loss of quality of life, and a common cause for sciatica or other nerve impingement disorders of the lumbar spine.
So I don't know a lot about it, but I guess my first question just a novice would be, what causes it? I know that it's something that usually, isn't it diagnosed at an early age, or is it not? Kind of give me some.
Sure. So it's a very non-specific term, and it just relates to references to a three-dimensional rotation of the spine. Now, there are several different types. Some are diagnosed in adolescents and in young kids, and then of course we see the adult type, which is called adult degenerative scoliosis, and that's what I see most frequently in my practice.
What does that mean? What's the difference between the scoliosis that you see in a child and then one that you see in an adult? What do you mean by that?
So cause is generally different. So in adolescents or in kids, we don't generally know the cause. They call it idiopathic, and so it reflects usually really large curves that we see that are, the ones that make all the headlines on TV with large S-shaped curves. Whereas in adults, we see what's more of what we call degenerative scoliosis, which just has to do with asymmetric wear and tear of the discs. So a lot of it's classically the apex of the curve is in the upper lumbar spine and it faces to the left, whereas the adolescent and juvenile scolioses generally have much larger curves with much more dramatic appearance, humping of the ribs, shoulder tilting, and we see that in the younger kids.
Okay. Is that usually something that they're born that way, or is it
so they're not generally born with it, but it does develop in young people. Typically, so there's a juvenile type and then there's adolescent type, and that just reflects age less than 10 or around the pubescent period up until early adulthood for the adolescent type.
Okay.
And those causes are not well understood, at least in the adolescent idiopathic type. And then there are other types that include kids that have neuromuscular conditions, and those kids are generally wheelchair bound, or they have a hard time to mobilize and get around very well. And so theirs is a different type and cause altogether.
Is the treatment the same for?
Hold on. So what we see most frequently in the adults are these lumbar degenerative scolioses, as I said. And if the patient has a well-balanced spine, meaning the head is centered well over the pelvis, not tilted to one side or the other or pitched forward, often we can try and treat just the symptomatic portion of the curve, whether that's causing sciatica or pain in the thigh or back pain, as opposed to correcting the entire curve itself. If the curves are more dramatic or the patients are out of harmonious spinal balance, and a corrective operation generally is performed at that time. And then in the young kids, there are particular treatment algorithms for the different types of curve, whether it's a single large curve or two large curves or whatever the cause. They have a particular treatment algorithm for that.
Okay. And so, and then in an adult that has the degenerative, what do you do for scoliosis?
So, as I said, it generally relates to the patient's symptoms. So
Okay.
if the patients have a good balance and just there's one disc collapse or two disc collapse that's causing impingement or pressure on one of the nerves, we can do a disc. We usually take the disc out and replace it with a cage to level out that collapsed
Okay.
disc to take the pressure off the nerve and realign the symptomatic portion of the curve. And
Okay.
we can do that through minimally invasive fashion. So we sometimes use a series of small tubes or small incisions to take out the disc and replace with bone cage and screws and rods where appropriate.
How common is this?
It's rather common, actually. So
Really?
with the wear and tear that we see in adults, it's just an age-related condition. We see it a lot of folks in their 50s, 60s, and 70s. Probably anywhere between like 2 and 5% of the population have some degenerative scoliosis. This is a relatively common condition.
Wow. So how do you prevent, I mean, let's just talk about the
Sure.
older. So how do you prevent that? What is it that, what causes it?
Don't get out of bed. So if you don't want it, don't walk. So it's just gravity.
Just don't go through life.
Yeah, unfortunately, gravity exerts its effects in all fashions and manners in every spot in the body. So
Gravity's mean.
it's unforgiving,
Yeah.
No, but so there's not a lot per se to prevent it. There's definitely some familial component. There's always a environmental component. People that are really active, particularly going to wear and tear. But the disc will collapse asymmetrically on one side or another, and then the spine will rotate around that collapse. So that's where this three-dimensional component comes in. But oftentimes, in many folks, the curves are relatively minor, and you don't have to treat the entire scoliosis. You just treat
Right.
the symptomatic portion, and most folks do really well with that. I would say a lot of the folks we see with this condition will say, "Oh, I've had some mild lingering back pain for a number of years. It's not particularly disabling," but then they'll get a sciatica or a nerve root impingement syndrome, and that's what really drives their morbidity. Or they'll get a foot drop or some neurological deficit related to nerve root compression, and that's what we try to treat. And there are some non-operative measures to treat that. But if there's a significant nerve deficit, then we try to treat that surgically and maximize the opportunity for recovery neurologically.
Okay. So what do you see in the future in regards to your specialization?
So there's been incredible advances in the field of neurosurgery in general, and particularly in spine over the last 5 to 10 years. We've, in the last 15 years, have developed new approaches to the disc, new approaches to stabilizing the spine from the old days where we made large incisions and dissected a lot of muscle, a lot of painful recovery for the patients. Now we're doing things through incisions that are under an inch, and we can get good access to the disc now without removing a lot of bone. And whereas before we had to take off joints to get to the disc space and risk the nerves. And so there's techniques now coming that are much safer for the patients, with better correction of the curve, with less morbidity and less time in the hospital than, say, even 15 years ago. So there's been a lot of improvement, and there's still more to come. Spinal robotics is an emerging technology, and it's still in its infancy, but we've published on it some. We found that right now it's limited in placing instrumentation, screws and rods and all of that. But in the years to come, we anticipate it's going to be more involved in the correction of the deformities themselves, making the cuts in the bone safely, and how to achieve the appropriate restoration of the spine where it's failing.
Okay.
We found that these patients do really well with even just smaller treatment as opposed to an enormous operation. And so what particularly fascinates me is how well someone can do through surgery with doing a relatively small operation for what looks like a humongous problem, and then patients having good return to function, quality of life restored, all of that with just a day or two in the hospital and seemingly very little intervention on what looks like a really big problem.
Yeah. It amazes me how important the spine is. And I guess you don't think about it
So
in
it's
your
not
day-to-day
working.
life, yeah, because with all of the nerves that run through that, and how it's just like almost your breaker box, so to speak, for your body.
Right.
That when you have a problem with the spine, you've got problems.
Right. Yeah.
Yeah.
So the sciatica is a major form
Yeah.
of disability, loss of productivity, loss of quality of life, days missed from work.
Yeah.
And so, oftentimes we can treat patients if they just have a disc herniation or something small. We can treat that conservatively, give them a shot or some medication to, take the edge off things until
Right.
it settles back down, and then then they can have that regained quality of and get back to work and improve quality of life. And in some situations, we see folks that have been disabled for years from work because of this untreated, degenerative disease of the spine or whatever the case. And those folks can even have much improved quality of life after surgery if or when they fail conservative measures.
What are some of the I know that we're supposed to talk about scoliosis, but
Sure.
what are some of the other things of the spine that that you treat, or other problems that are encountered?
So, as we were talking, this wear and tear of the disc
Yeah.
and degenerative disease of the spine come in a lot of shapes and forms. Some people develop what's called a slippage, or what we call spondylolisthesis,
Yeah.
where instead of the bones stacking normally, they might slip forward. And that's another hot topic issue at all the national spine meetings that we're studying, trying to determine, do all these patients need fusion for these slips,
Right.
or can we just treat them with decompression, take the pressure off the nerves? Is that enough? Do they need a bone cage to realign and to support the disc? And so this is an emerging, well, I should say it's not emerging, but it's an area of ongoing debate, and there's a number of trials out there that it's really hard to assess some of these conditions in a trial. But we found that surgery has been definitively proven in a number of good studies over non-surgical management, and oftentimes fusion has been proven to be superior to just decompression alone in these same patients. So spondylolisthesis is a condition where we see quite a bit, what we call spinal stenosis, where there's just compression around the nerves and the nerve sac. That often causes people to have pain, or their back fatigues when they walk, or they may have leg pain, what we call claudication. These patients often present, they'll say, oh, when I go to the grocery store, I've got to lean forward on the grocery cart. When I lean forward, my legs get relief, and they're able to, say, walk to the grocery store. And you say, how far can you walk? I can't go a city block before I have to stop and sit down. So the legs really fatigue a lot. The nerves don't get good blood supply to supply the functions to the legs. And so that's a condition that's tried and true, proven to be, responds very favorably to surgery in most cases. So patients with that condition do very well.
Yeah, there's just, again, there's just so many things that if that's not working right, you've just really got problems.
Right.
Yeah.
We see the same thing. And another interest of mine is what we call cervical myelopathy, so pressure on the spinal cord. It's a condition mostly we see in the cervical spine. Again, it's usually related to degenerative disc disease, or disc herniations occasionally can cause advanced myelopathy or pressure on the spinal cord. And those patients exhibit progressive weakness in the hands, loss of functions, poor balance. They can get weakness or wasting of the hand muscle groups occasionally. And so this is another condition that, if left untreated, patients can have severe morbidity, lose ability to walk, or have falls, put themselves at risk for a lot of other progressive type problems.
It's just amazing, because I can sitting here and I'm thinking of so many people that I know that have these issues. I mean, it's
you throw a rock,
very
you're going to hit
common.
somebody that's had surgery for their back or neck, or that probably needs it. So it's just part of the aging process, wear and tear and all of that. Now, everyone has age-related wear and tear, and that's all, you can't get away from it. But the reality is there's normal, healthy aging of the spine, which is the arthritis and all that sort of stuff. Then you have pathological aging of the spine, which is where there's pressure on the nerves or the spinal cord, and same thing in the low back, pressure on the nerves or the nerve sac, and causing all this conditions we discussed. And so we have to try to tease out who's having normal aches and pains related to aging and who needs something done here. And so,
Yeah. I had a doctor tell me he couldn't cure arthritis.
well, if I do, I won't be doing this for long, that's for sure. So,
Yeah.
keep my fingers crossed for that. So.
How would we get a hold of you? So if we're experiencing any of these issues, how do we get a hold of you?
So our office number is 682-219-0357. And we're the brain and spine specialists of North Texas. My full-time practice is in Arlington at the professional building at Medical City of Arlington. We also have an office at 3141 Broad Street, where we come out here about once a week to see patients as well, if for the folks who aren't able to make it over to Arlington.
That's good. That's really good to know. Yeah. Okay. Excellent. Well, I appreciate your time.
No, thank you so much for having me.
Yeah.
And we look forward to hopefully serving the Arlington and Mansfield communities very well.
Absolutely. Thank you.
Thank you so much.